which really kind of leads us to the non-corneal options, which really is what we're talking about now. And I think the ICL has been the newest version, the EVO version. If you're not putting that into your practice now, you're really missing an opportunity. You can change people's lives. The ICL is approved down to -3, and I think that many surgeons start using it routinely at a little higher levels, maybe 6 and above. But from a practical standpoint, it is a straightforward procedure that has amazing visual quality. So from our perspective, we really do look at what's going to be a lifetime of good vision. And with the EVO now not needing a peripheral iridotomy and the incidence of cataract, which was low to begin with, now it's virtually close to zero. It's been, and that's just been proven time after time with multiple large studies. So the ICL has become a more important part of what we do, just because it covers those high myopic corrections in a way that gives not only good quality, but is safe. And these are individuals who've been turned down, who are told you can't do anything. Well, that's just not true anymore. They have that opportunity. And I tell you what, your practice will become a hero within their world if you would do that.
Yeah, I can probably speak to a little bit of personal experience with ICL. I didn't know what ICL was, John, until I met you back in 2019. Yeah, you told me about it. It was before EVO. It just wasn't a very common thing, at least not in Michigan where I was from. We didn't have anybody doing ICL. And we saw, I mean, the previous version did come with some issues. There was a real chance at pupillary block and angle closure, and we saw some of those patients. Sizing the ICL, the Visian ICL, was a challenging thing, and it was kind of hard to get right. But with the introduction of EVO a couple of years ago, I mean, we haven't seen any issue. The lens is extremely forgiving. The eye can withstand a pretty high range of volt. And because of the aquaport in the middle of the lens, there's going to be aqueous flow, which is going to bathe the interior surface of the crystalline lens. So the chance of cataract is almost nothing. The chance of pupillary block is almost nothing. I guess technically you can have angle closure if the lens is just way high volt, but that's really hard to do. It can be done, but you really don't see those risks anymore. And the optical quality of it is just impeccable. I mean, if you look at the FDA studies, how many people actually gained lines of best corrected vision with the ICL after? That, I think it was 52% or something like that, 53%, around there. And why is that? It's really because of where you're correcting the vision. A high level of ametropia, you're correcting at the nodal point, which is right at the front surface of the crystalline lens. And so theoretically, right, if you can correct vision as close to that spot as possible, why not? And that's what the ICL is doing. So we get patients who come in and they're -12, -13, they're best corrected 20/25 maybe. And the refraction is always kind of rough because they just eat up minus. But if you get a good fitting ICL and it's the proper power, that patient comes back there 20/20 plus routinely. And it's shifted my thought of where I've got this big diagram, this big Venn diagram in my head when I have a patient coming in for a LASIK consult. LASIK, we've got ICL. And there used to not be much overlap. In my mind, it was LASIK for anybody -7 or -8 or under, and then anybody over that, that's ICL. Well, I find myself having real honest discussions with people as low as -3. If they're -3, they can do an ICL. And there are certainly advantages of it over traditional refractive laser vision correction.
How high?
And so I have open discussions.
How high can you treat with the EVO lens?
The strongest power lens you can get is a -16. And so it's FDA approved for the reduction of myopia up to -20 and the correction of myopia up to -16. We've actually treated several patients that are -20 and even more, and we'll do a bioptics or combination approach where we'll put in a 16 diopter lens and then go back to the cornea to do laser vision correction. So we've got a couple of patients that we took from -20 to 20/20, which is one of the most fun experiences to be able to deliver to people. Yeah. It's incredible. So you think about how you could change someone's life in that way.
Even if you don't have access to an excimer laser, if you take someone who is -18 or -19, what have you, and you leave them a -3, it's changed their life. They're no longer hiding behind these thick glasses that they have limited selection of rims and contact lenses that aren't thick and uncomfortable. So you can have patients who, again, just think you've made their life that much better by making them -3 when they used to be -18.
Mm-hmm.
So, keep that in mind. We strive for emmetropia because we still think about that as the ultimate end goal, which obviously we want that. But, you can leave someone a little bit on the minus side and still be extremely pleased. It depends where they start from.
So what about patients with like keratoconus or ectasia? I mean, can you do ICL in those patients?
Yes, we do that routinely. We've published on that actually, and Brett Mueller presented a big paper at Academy a couple years ago with a few hundred eyes where the corneal topography was at least borderline, if not frank keratoconus. It's extremely effective. And, a lot of times depending on the severity of the keratoconus, we might coach the patient ahead of time to say, you might need some thin spectacles or something to wear once in a while. We might at minimum reduce the amount of refractive error, but interestingly enough, the patients often see better than we thought they were going to preoperatively. That's very, very effective in that population.
Yeah, there's one patient we did in particular that I can remember. He was like a -20. He was over -20 and kind of a form fused. His corneas were regular. And I remember he came in, and I'm usually the first person that they see when they come in for any sort of evaluation. And I was like, well, hey, man, we can only get you down to like a -5-ish. And you're still probably going to need glasses. He could not wear contacts. He just couldn't tolerate them, couldn't get a scleral lens in. He was wearing these Coke bottle glasses that they looked horrible, and he couldn't see very well out of them. And I mean, even though we weren't going to get him anywhere close, in my view, I'm going for perfection. Being in refractive surgery, I want perfect. And this was going to be far from perfect in my eyes, but to him, it was life-changing. I mean, it really was. He could wear glasses now that were at least not highly, you're not inducing so much minification from a -22 lens. He was wearing a -4 lens, and, he was presbyopic too, so he could take his glasses off and read relatively comfortably, at least holding things pretty close. And I think we even eventually got him into a soft contact, if I recall. This was a couple years ago. But just because you can't get all the refractive error, you can definitely change somebody's life. And I asked him again. I see him now annually. He's my patient. I've adopted him. Would you do this again? Oh, 100%. Doc, you changed my life. And I didn't. I mean, John, you changed his life. But I'm happy to be there for some of the credit. And it is very rewarding. So what about other corneal pathologies like Fuchs? I mean, can you do something like that for Fuchs? Maybe early Fuchs? Is that something that's possible with ICL?
Absolutely. I mean, that is another thing where we know that patients who have Fuchs, they don't do well with multifocal IOLs. They commonly don't do well with LASIK. But with an ICL, they're going to have very high quality of vision, or at least as high a quality, depends on the level of Fuchs, obviously, but it is very high quality vision. And when you do an ICL in a patient with Fuchs, you've not made it difficult or unreasonable for them in the future to have endothelial cell transplant, a DMEC, a DWEC, or other procedures, because the ICL is behind the iris and it doesn't interfere with the corneal procedure.
Does it change how you approach cataract surgery? I mean, it's reversible. Does it change at all the strategy for a routine cataract surgery in somebody who's got an ICL? Is there any surgical tips, techniques
really
that you guys have?
Doesn't change it much. A lot of people wonder, can you still get a biometry measurement through the ICL? Is there any sort of nomogram adjustment you need to make with your IOL power calculations? And the quick answer to that is no, it makes no difference. So you can just take a regular IOL master, however you do it, and the ICL in the eye doesn't change those calculations at all. You can also perform femtosecond cataract surgery with an ICL in place. I personally use an Ally from Lensar, and we were able to still use the femto treatment right through the ICL, remove the ICL, remove the capsule, and complete the cataract surgery just like we would, with the only addition of slipping out the ICL at the same time the cataract's coming out. I would say the one advantage of ICL in this setting when it's time for cataract surgery compared to the alternative is that since you've not changed the corneal anatomy at all, no induction of any sort of, higher order aberrations to the cornea. The patient's options are maximally open in terms of what type of IOL we may consider for that patient when it's time for cataract surgery. So it's pretty straightforward to perform the procedure. Not many special considerations other than just remembering to take it out.
I think that's one of the most underrated things, that it's hard to explain that to a patient, that once you become cataract age, and especially our ICL patients tend to be a little bit younger, cataract age is just a hypothetical year down the road that they don't want to think about anyways. But having their best interest in mind, cataract surgery at that point, if you're leaving the cornea completely preserved and intact, you have every option on the table. You don't have to worry about something that, uses higher order aberrations to extend depth of focus or anything like that. So it does become easier.